Thank you very much, Max. Thank you very much, Stefan and Marcus, again for inviting me to this meeting. It's a great honor and pleasure to be here. I'm going to talk about the Propionibacterium acne, the challenging bag, and to understand exactly what we're dealing with. In order to confuse us, they changed the name now to Cutibacterium acnes, so it's a bit more confusing. These are my disclosures, but none relating to this. So P. acnes, or Cutibacterium acnes, is a non-spore-forming anaerobic bacillus. It's bacteria in the deep layers of the skin, respiratory, digestive, eye mucosa, and it's got low level of virulence, but I think its pathogenic role is now quite clearly established. It's believed to be of low pathogenic potential. Its isolation is difficult. We need prolonged cultures, at least 2 weeks. And any conventional cultures that are thrown away after 48 hours will miss the P. acnes. Now, using conventional microbiological techniques, in significant number of cases, we will find them negative and will not identify the P. acnes. So we actually looked at it, and between 2008 and 2010, we collected fluid and tissue specimens from the glenohumeral joint in very strict, meticulous techniques. We changed the instruments. We did a very sterile, non-touch technique to do it. And in microbiology department, it was really under strict conditions. And we looked at 55 consecutive patients undergoing primary total shoulder replacement for arthritis without any preceding signs of infection. And again, we excluded any cases that might have had some source of infection, any previous surgery to the joint, previous proximal humeral fracture, intra-articular or subacromial injection in the year before surgery, antibiotic treatment for 2 weeks prior to the surgery, or any clinical or radiological signs of infection. So we withheld the perioperative prophylactic antibiotic treatment until we take the specimens, and we took 6 microbiology specimens and 1 histology specimen, and all of them were transported to the lab within 1 hour and processed immediately. We had a strict laboratory protocol and under severe QA class 2 laminar airflow cabinet. So between these 2 years, these 55 patients, there were 17 male and 38 female, mean age of 72.4. 31 were resurfacing shoulder arthroplasties and 24 reverse shoulder replacements. And the joint fluid was classified as positive for P. acnes in 23 patients out of 55. This gives us about 41.8% of this primary total shoulder arthritis without any signs of infection. So we had a very strict definition on positive cultures, and we had to have at least more than 50% of the specimens positive in order to define it as positive. It was less than that. We thought it might be a contaminant. We did an histological examination as well, and this showed just a chronic inflammation with some infiltrate of lymphocytes and plasma cells, and there were no classic signs of bacterial infection, means 5 polymorphonuclears per high power field. So this was diagnosed early, about 5 to 7 days after surgery, and all these patients were treated empirically with antibiotics, with double drugs, either clindamycin and rifampicin, or amoxicillin and rifampicin, empirically for 4 weeks. There was no signs of any infection in none of these patients so far. All made very good and full uneventful recovery, and all returned to normal, and there was no inflammatory signs or inflammatory markers in the bloods in all these patients. So P. acnes colonization of the human shoulder has been described before, and the question is whether P. acnes may have a role in the cause of osteoarthritis, and this was one of the questions we raised. So we know that there's some infectious arthritis caused by P. acnes. It showed there was a case report about that by Bertin, and actually this was isolated from a synovial fluid in patients with oligoarthritis associated with acnes and pustulosis. We know as well that arthritis was caused to rats by injection of P. P. acnes into the joint, and this causes erosive arthritis in these rats. We have some other case reports of infectious arthritis caused by P. acnes, and a report of a couple of cases, and West Nottage and his group actually found 19.6% positive deep cultures of P. acnes in arthroscopic shoulder surgery. This is a study from Robert Hudek and Frank Golke that they found as well positive cultures for P. acnes in 36.4% in the joint, and the subacromial injection was not in that case associated with bacterial growth rate, and the preoperative antibiotics were withheld the same as we did before the samples were collected, and the deep samples were more often positive than the superficial samples. A recent study from Düsseldorf by Thilo Patzer showed exactly similar things, that the intra-articular specimens were much more often positive than the subacromial ones. So we know that there are different P. acnes, there are different bacteriophages and different subtypes that might differ in their pathology, and some of them might be more aggressive or much more creating inflammation than the others. And these bacteria are infected, viruses are common in nature and outnumber bacteria 10 to 1. Phages can be found as prophages inserted into bacterial genomes, and most probably some of these will become more aggressive than the others. So what is the significance of these tests? Is this an infection, what we found inside the joint? Is it a commensal organism present in the joint, or just a contaminant? And this is still an open question. So there was a group in Australia that tried to repeat our study, and they actually found a low rate of positive cultures for P. acnes, and actually they really annoyed me because he said using a strict specimen collection technique, actually maybe blaming us, Robert Hudek and myself and Frank, that we are not doing it really in a clean way. And we did it a very meticulous way, and again, the major flaw in this study is that they gave antibiotics a few minutes or a half an hour before they collected the specimens. And we know that P. acnes is very susceptible to antibiotics. Maybe you won't kill it, but you won't be able to grow it in the culture. And if you give antibiotics, you cover that. So again, there was a study by Rick Madsen and his group that showed that even with antibiotics, you can still grow the P. acnes. Yes, you may grow it, but if you don't grow it, it doesn't mean that it's not there, because if you gave antibiotics, you covered it. So as we said, it's very susceptible, and I think what we need to do is to use the same technique, the adopted technique that we use in revision surgery, that we withhold antibiotics until we take the specimens, and then we give antibiotics at 30 minutes before we implant the implants, and this will be actually according to the protocol of implantation with antibiotics. So we know, and take it further, we know the study from the Mayo Clinic that in Topolsky and his colleagues, they found that 60% of the so-called aseptic loosening for revision shoulder replacement were actually eventually positive for P. acnes. We know again from a study by Levy, not related to me, that 56.3% of the patients, again with aseptic loosening, were positive for P. acnes. And we see it more and more often now. Pottinger, again, 56% of the revision cases for stiffness and pain and loosening were positive, and 70% of them were positive with P. acnes. We know a study from J.P. Warner and his group that in arthroscopic tissue biopsy, evaluating prosthetic shoulder infection in patients with painful stiff shoulders, again, in 41.2%, they have found positive for P. acnes. So maybe this P. acnes has got something to do with this painful stiff shoulder arthroplasty. And these are some of the papers, excuse me, some of the papers that came out following our paper with the P. acnes, trying to find or to refute what we've said. So maybe the unrecognized low-grade infection at the time of the primary joint replacement may be responsible for this painful joint replacement, stiffness, and so-called aseptic loosening. And what about histopathology? As I said earlier, We didn't find any classic signs for bacterial infection, like the 5 polymorphonuclears per high power field, but we found chronic inflammatory cell infiltrate, like lymphocytes and plasma cell, more like a viral infection. And again, if we look back in 2009, Alberto Snieberger and Christian Gerber, actually Alberto described 9 cases of so-called infected shoulder, but he couldn't find any bug. And the diagnosis of infection could be challenged by 2 aspects, that they didn't fit the classical presentation of bacterial infection, and the patient did not present with typical signs of infection. They didn't have any swelling, fever, pus, etc. And there was a mild or minimal or moderate intra-articular inflammation. They couldn't find any inflammation. And microbiology actually found no microorganisms in this, and actually just only few leukocytes. So actually, again, we know that the sensitivity of frozen section or histology for P. acnes, it's pretty poor. And this study from Australia that I mentioned before, they said that no, it's not infected because they couldn't find any 5 polymorphonuclears per high power field. But if you, actually, the problem with that is that if you look for the coin under the lamppost, you won't find it. What you have to do is to look and find where the coin is. And if you look carefully, again, if you look at this, at their cases, 65.7% showed chronic inflammatory cell infiltrate. So maybe if we look like this, we will not know that it's here. But if we open our mind, we can see maybe it's a different bacteria, it behaves differently. And again, possibly that this bacteria give a chronic low-grade infection with lymphocytes and more polymorphic cells, more like a virus. And could be that the P. acnes have a role in the pathogenesis of osteoarthritis equivalent to the Helicobacter pylori, and in the development of gastritis and duodenal ulcers. And we know that H. pylori is a gram-negative bacterium found in the luminal surface of the gastric epithelium. The first described in 1983. It induces chronic inflammation of the underlying mucosa, characterized by high concentration of lymphocytes and plasma cells. And more than 50% of the world population has got a colonization with H. pylori, but not all of us are developing gastritis, and very similar finding to what we found actually in the synovial submucosa. And similarly, in our series, we observed chronic inflammation in the civilium of the joint without any clinical symptoms of infection. The histological inflammatory range between mild and moderate changes, and this may reflect a very low-grade infection with P. acnes, and which this might be the trigger, the trigger for the inflammatory process, release of inflammatory cytokines, and leading to osteoarthritis. So this is our hypothesis, and this might be the cause, or one of the causes of osteoarthritis of the joint. And just quickly, we know that disc degeneration is being now related to P. acnes as well, and this spinal disc disease. We know that prostate cancer as well is being linked to maybe an infection or low-grade infection with P. acnes. And so to conclude, for many years, P. acnes has been an infective agent, and now we are pretty sure that this got a place in shoulder surgery, and it might be we need to be a very high index of suspicion and suspect all these cases with this painful, stiff shoulder as infected with P. acnes. We have to improve and keep our high suspicion. We have to improve our techniques and maybe use PCR, like